Assalamu alaikum wa rahmatullah wa barakatuh. Hello everyone and welcome to our webinar. My name is Noor Al-Madaj and I am an occupational therapist from Kuwait, specializing in unit and early intervention. And I'm the founder of this group, Occupational Therapy Support Group and Resources. So today we have with us Dr. Sukaina Dada. Dr. Sukaina have 15 years of experience in pediatrics population. Hello and welcome, Doctor.
Thank you. Thank you. That's very kind. Hello, everyone. Assalamu alaikum. As mentioned, my name is Sukaina, and I am actually speaking to you from Toronto, Canada. I am a pediatric occupational therapist here and very, very interested in this topic, listening to untold stories, examining and supporting intersectional needs of displaced children and their families. And the objective of today really is for pediatric occupational therapists, and actually all occupational therapists, the need to examine the critical intersection of disablement and displacement. So just to give you a background about me so that you know the position that I am coming to this conversation with, I am the executive director of an organization called Smile Canada Support Services, where we are supporting around 750 families, children with disabilities and long-term health issues in Canada. But many of our families have transnational, experiences of disablement and displacement. We support many families from Syria, from Somalia, from Yemen, from Afghanistan, and most recently from Palestine. And those families are not coming as refugees, but some of them are coming as evacuees. And of course, there is a lot of concerns that we have within our healthcare system. And I think sometimes people who are outside of the global north or outside of the West, they have this false impression that here, all individuals are served and treated equally and fairly, and that is far from the case. I did a PhD on disablement and displacement. Following my career that began in occupational therapy, I was really struggling with the policies around supporting children with disabilities, specifically around displacement. I find that although there are very significant numbers of displaced children who are disabled or who have disabilities, because disabilities are a direct result from war, from structural violence, from trauma, yet this is something that is very much ignored within occupational therapy studies, within migration studies, and within critical disability studies. My area with regards to pediatric occupational therapy is mostly to work with children with developmental disabilities. And I am very, very honored to be here amongst all of you. And I'm honored that you selected me to speak to you. I hope that if I can share anything that is of benefit to you, that inshallah I do. And I also hope to learn from all of you. Please, please, please get in touch with me. So what I want to do today is just go through a few different slides that direct us to this topic. And I frame the topic as a problem. And the reason why I frame the topic as a problem is because when we frame something as a problem, then we know that we need a solution to combat that problem. If there wasn't a problem that existed, then we wouldn't be searching for those solutions that would then, be able to combat this problem. I'll move on to a slide titled Health, Disability, and Politics, because we are in a socio-political climate whereby many people find it difficult to express their concerns within a healthcare space. I will move into what's called a dominant narrative, and this is the philosophical or methodological approach that I took in my own PhD studies. And then I'll move into some theoretical frameworks, which might not be new to any of you, but would maybe highlight some of the theoretical frameworks that are significant within disability studies and of course, healthcare as well. Finally, just moving into the conversation of challenging systems of oppression within healthcare, and specifically as occupational therapists, how we are instrumental in doing this. And I'll leave off, with healthcare as advocacy. So that sounds like a lot, but I hope not to talk too much. I'm really interested in listening to your questions as well. And like I said, I hope this is an opportunity for me to share some of the knowledge that I've learned, of course, knowing full well that I am sitting in a privileged position here in the West, and that I'm doing my best to learn and about the situations around the world, and doing my best to advocate not only for children with disabilities, but specifically within the context of occupational therapy. So I mentioned that, there is a high correlation between children with disabilities and displacement. We know that war, conflict, genocide, apartheid, occupation, they all have a direct impact on children with disabilities. Children become part of what's known as a disabling system, a system that impacts their physical disability, their physical well-being, their emotional well-being, their mental health well-being. And as a result of that, or one of the results, is that they get now introduced to a healthcare community, of which occupational therapists, they might not be part of that, but they could be. And the reason why is because of our approach to meaningful, purposeful occupation. With regards to disabled children, one of the things I wanted to point out is some statistics. Now, you'll notice that these statistics are not from 2023 or 2024. This is a concern we've had for decades, because we always know that there is an impact on disability and displacement. There's a correlation there. Disabled persons, according to the Women's Refugee Committee, a report that came out in 2013, are the most exposed and excluded groups of any displaced community or society. Disabled persons are ignored within humanitarian spheres, including programs specifically designed to support displaced persons. Disabled persons are left off. And when I say disabled persons, I'm using this word not necessarily about the individual, but I'm using it as like we say, racialized person. Society is the one doing this to that person. And as a result, the person is found within this disabling space. But it's ironic because humanitarian spaces, including hospitals, including clinics, that are designed to support displaced persons, statistics show us that persons with disabilities are the least on the list to get quality care. So we have to ask ourselves why. Why is that? And one of the answers that appears over and over again within the data is that there's this survival of the fittest mentality, a mentality that has overtaken disability studies and spaces of persons with disabilities for decades. And that is that we, as a society, we put a value on an able-bodied person over a person with a disability, whether that's a physical or cognitive, intellectual, sensory, self-regulation behavior, it doesn't matter what it is. We put a value on a person who doesn't present with certain characteristics, certain features, and certain abilities. And so as a result, we see that within our own spaces, that there is such a neglect for persons with disabilities, and specifically children with disabilities. Another statistic that comes about from a scholar, a disability and migration scholar named Mary Kroc. She's written a book on refugees with disabilities, that disabled persons are at higher risk of physical and sexual abuse, exploitation, abandonment, and of course, death. We also know that there's a fear of reporting, even to healthcare workers, a fear of reporting post-traumatic stress, a fear of reporting emotional, any kind of emotional distress, and also a fear of reporting physical disability. And I'll explain that in the coming slides. There's a famous quote by a scholar named Kane, and I'll put all these references at the end. And the quote is that our bodies tell stories. As human beings, our bodies that have been, harmed or hurt or policed or threatened, our bodies that have been exposed to difficult situations, exposed to displacement, that have lacked water or food or medicine, our bodies tell our own stories. And I want to give you an example of somebody that I had the privilege to interact with, a Syrian family, a Syrian child, in 2022 when I was completing my dissertation at York University in the School of Health Policy. And specifically, I've put this parent's quotation in this presentation. And the quote is that when he was 3, as in talking about the child, we took him to a doctor in Lebanon, and the doctor said that the child has a high metal and high toxicity rate. It could be a result of chemical poison he was exposed to, but in Canada, they don't believe me. They say he has ADHD and autism, and that we need to stop talking about what happened in the war and focus on treating him. Now, like I mentioned, I reside in Canada, and my work specifically has been in a Canadian context. So I don't want to misspeak for anyone, and I don't want to pretend like I know what it is for many of you working in different countries. However, one of the things I do know is that many of what I'll share, you may resonate with, because oftentimes healthcare workers are trained to not listen to the story of the patient or the client, but instead to put our own expertise and our own information together and say, we are the experts and we know how to best support your child. In this case, the mother was talking about chemical poisoning. But the child, according to occupational therapy, physical therapy, and speech and language and educational assessments, was presenting as somebody with attention deficit hyperactivity disorder and the autism spectrum disorder. And so as a result, the child was just said, okay, you have autism. Khalas, like you have autism. And the reality is the mother is saying, but who is going to address the fact that my child was exposed to chemical weapons? This is where our bodies tell stories, our voices, our sight, our hearing, our physical movement. And these stories that we're telling are stories of ourselves. We are the experts. We often talk about client-centered care in occupational therapy, but client-centered care without listening to the narrative of a family is absolutely meaningless. But I want to backtrack to this concept of the dominant narrative. Now, this might be something that you haven't really been exposed to in your clinical settings, or maybe even in your schooling in becoming an occupational therapist, because it's a little bit outside of the medical model and the conversations in healthcare. But this is something that I am very passionate about because I believe dominant narratives, especially in 2023, 2024, where the world has really turned their face away from protection of children, protection of hospitals as sanctuaries, protection of healthcare workers. The danger of a single story is a concept or a phrase that was coined by Chimamanda Adichie, who is a historian, a storyteller, a novelist, an educator. And this concept of the danger of a single story is that there is a single story repeated over and over and over again, and that is the only story we are allowed to believe. Now, this story affects all of us. As people of color, as people of a certain faith, as people of certain nationalities, these stories tell us who walks into our clinic, who we're going to believe, and who we're not going to believe. And these stories are embedded in our literature, in our textbooks, including in our occupational therapy textbooks. They are embedded in our universities, they're embedded in our policies, and they're embedded in our legislation or in our laws. But mostly what we're seeing today is they are embedded in the media. So I want to give you an example. And on the screen, you'll see there's an example of something at the top and something at the bottom. At the top, you see an image of a middle-aged white woman. And this was featured in one of the newspapers in Toronto. And it says, "A tireless Canadian protector and guide, wondering how much more can she do?" In the top one, this picture of this woman, she doesn't look scary. She looks like she's able-bodied. She looks like she's well-to-do. But the phrase that sits beside her face says that she's exhausted. How much more is she going to do? And here we flip the conversation. The conversation is not about the client, not about the community in need. The conversation is about, and I put this in air quotes, it's about their protector. This is a very dangerous story, and this story often seeps into healthcare narratives, where the conversation, as well, the therapists try to do their best. It's not their fault. The client is so complex. This is very dangerous. And we have to pay attention to the social, political, and economic context that surround the narratives. On the same token, at the bottom, you'll see a picture of what looks like women in hijab, Arab women in hijab, and they're actually behind a bar. Now, this picture was not taken in the Middle East. This picture was taken in Canada, but it appears like they're in some type of prison. And in big, big letters, you see to the side of that, illegals have landed. Now, why does this have to do with healthcare? Because healthcare workers are also reading this. Healthcare workers are also exposed to these dominant narratives, which is why I present this to all of you in this conversation. The purpose from my understanding of these conversations is for us to go back into our own spaces and really do our best to advocate for our clients who are facing unprecedented times. The profession of occupational therapy is largely silent on oppressed, non-dominant stories. Now, dominant narratives, they also oppress non-dominant stories by taking them over while obscuring the very means they are produced. What I want to mention is that dominant narratives are not simply stories we can ignore. They influence the world's economic, social, and political movements, including within healthcare spaces. So it's something to think about. It might be something that, doesn't usually come up within clinical conversations, but I urge you all to think about the context of dominant narratives within our spaces, whether those spaces are virtual or online, or whether those are clinical spaces. This concept of disablement and displacement. So we usually, as clinicians, talk about disability from a more medical standpoint. We talk about diagnoses, we talk about assessments and interventions, and that is all well. However, there's this concept of disablement in relation to displacement that oftentimes we don't talk about. And this concept of disablement is a process rather than an identity. If I identify as somebody like the young man that's featured on the screen, he has cerebral palsy. He identifies as disabled, and all of the people in my presentation today, they're all young children who I get to work with in my work at Smile. So this young person, he has cerebral palsy, and so he identifies as somebody with cerebral palsy. As somebody with this disability, he has difficulty with communication, difficulty with mobility, gross motor, fine motor, etc., etc. But at the same time, he's exposed unwillingly to this process of disablement. It's a process whereby people experience and become categorized. This is a young person, a person of color, a person who identifies as Black, as Muslim, as Sudanese, and somebody who is disabled. So how does that prevent him from accessing services and supports? This process involves both the social construction as well as the social production of becoming disabled and displaced. Within our spaces, we need to have, within our clinical spaces, we need to intentionally make space for the narratives of people, the narratives of our clients. I'm going to share with you a real case scenario. Of course, I've changed the identifying information of the client, but this is a real case scenario. Most recently, about 2 weeks prior, we had a young child who came as an evacuee with autism to Canada. The parent reported that the child is experiencing a regression of toileting, a regression in communication, a regression in motor skills, and the child is nonverbal, but producing increased vocalizations. The child's hands were constantly over their ears, and they were in a constant rocking motion. The child wouldn't let go of their parents. They would wake up in the middle of the night screaming and wetting their bed. The child had a loss of appetite, and until then, they had not received any services. Now, what happens is if the child is just treated on a checklist as somebody with autism spectrum, on the autism spectrum disorder, on the spectrum, then all of the experiences the child had in relation to the overstimulation of hearing and of sight, in relation to the excessive amount of grief the child has experienced, in relation to all the changes. We know that many children with autism have difficulty with change. Here you have children who have moved from camp to camp, from area to area, forced displacement internally, and then forced displacement externally. And what happened is when this family met a physician, a pediatrician, the pediatrician and the clinical team did not address any of the experiences of the child. They just went in with standardized assessments for those with autism. Now it's extremely problematic because we are not benefiting. In fact, we may even be harming those children and those families. So the big question is, as occupational therapists or anybody who's part of a clinical team, how can we support? Now, I'm not going to tell you anything you don't already know, but what I'm hoping to do is bring in some of these conversations around the intersection of displacement and disablement. We know that our assessments from an occupational therapy lens are client-centered and family-centered. But what does that mean if we are ignoring the family's narrative? Do we utilize standardized assessments that apply to the populations we are working with? Now, of course, as clinicians, we want to be evidence-based. And so we use evidence-based assessments. But they're evidence-based according to who? And I might sound very controversial saying this, but we have to look at which clientele those assessments were conducted on. Many of the assessments you get in the global south are designed in the global north with a standard white middle class population of children that don't represent many of the clients that we work with. I'll give you an example. In an occupational therapy assessment, there was, in one of the assessments, there was a checklist for fine motor, and the activity was tying one's shoe. Okay, I don't know about you, but I have children who never have shoes with shoelaces, because nowadays you can get shoes without shoelaces. Or there's another assessment that looks at children who utilize a fork and knife to eat. In many of our cultures, we eat with our hands. And so what happens in standardized assessments is those children then get marked off as not complying or not completing. I'm not saying we throw all of it into the garbage. What I'm saying is, are we constrained with the assessments that are presented before us? And are we constrained with existing protocols? And if we are, what do we do about it? We have to vocalize and utilize our own expertise in the area. Because at the end of the day, when we talk about occupational therapy, we are talking about meaningful, purposeful engagement, participation in occupations that people need and want to do. So as a result, if our assessments are not in line and not supporting those displaced children that we are receiving as clients, then we are effectively ignoring their stories of trauma, of pain, of structural violence, etc., etc. And if we ignore their narratives, then we are not at all operating from a lens of client-centered care. Similarly, when we identify goals based off of assessments that don't include our clients, the discussions and observations that come about from those assessments, it means that what we have to do is really work with the child and family to identify specific goals that are not necessarily standardized. They could be outside of what we deem to be most essential. When a child has gone through so much trauma, so much grief, so much physical disability, identifying goals may not be easy. However, the standard goals that we're used to, the ones that we learned about when we were in school, the ones that we learned about in clinical placement, they may not be the goals that a family is interested in. I was working with a client overseas whose goal was to survive. And that threw me off. It startled me because how do I, as an occupational therapist, consider a goal to survive when I don't have the power as a clinician to be involved in that person's survival? However, when we broke down what does it mean to survive, what does it mean for you, we were able to get to these activities or these smaller goals that really lent themselves to the child and the family's occupation. Finally, on the slide, when we're planning for intervention, are our interventions based on standardized assessments and protocols, or are they based on inclusive of experiences? Just a few days ago, I had traveled to East Africa, to my home country, Tanzania, where I saw an occupational therapist with a client, and they were constantly just moving their fingers. The client had contractors, and the therapist was engaged in this passive movement. And when I asked, what is the purpose of that activity? They said, no, you know what? We're looking at range of motion. But the client was just sitting there passively while two different therapists were moving their hands. There was no discussion about what to do, how to do it, where to do it, how they're going to be involved. It was just completely outside, and the client was not involved at all in that process. In my personal opinion, and like I said, I'm coming to this conversation as an outsider, as somebody who is outside looking in, I believe that in the field of occupational therapy, we are in a pivotal moment. And I thank the organizers for this, because we are in a pivotal moment to provide education and support to the wider healthcare community. OTs provide education and support to a child's family and caregivers, equipping them with knowledge and skills that are necessary to support a child's development. However, OTs also in doing this may advocate for the rights and needs of displaced children within our communities, helping to ensure access to appropriate services and resources. I'm going to take a brief moment to just go over some of the models of disability which don't always make their way into our clinical education. We often are focused on a biomedical model, as we should, and I'm not saying that any of these models are bad, What I'm saying is stand alone, we have some concerns. Because the biomedical model, we're looking at preventative measures of disability and impairment, and we're looking at treatment and cure. And there's nothing wrong with that. All of us, if we had a specific diagnosis, we would look to see how we can improve our physical and our emotional well-being. However, standalone, when we just look at the biomedical model on its own, then we're not taking into account the disabling systems that surround us, that make and keep people in positions of vulnerability and in positions of harm and fear and unsafe and honestly dire positions that we all on this call, we know of. The social model of disability is where we say that there are social systems that surround us and social structures that we have to change those systems even from within a clinical setting. And we have to ensure that our environments are places whereby people can, improve, develop, grow, learn, all of those things. The human rights model of disability is something that is heavily critiqued in this day and age because we know that we see even within healthcare, certain people are granted healthcare rights and certain people are not. Certain people get access to healthcare and clinical supports and certain people do not. And so as a result, we say that everybody has those human rights, and that's embedded within our profession as occupational therapists. It's also embedded within terminology that has risen from within the profession, such as occupational justice. There is a human rights component to our profession that says every child, every human has the right to do and engage and participate in the things that they need to participate in, such as education, such as activities of daily living. And we don't allow for disability or illness to prevent a child from doing that. And as a result, our profession has really grown to empower people. Unfortunately, even within our profession, there is this idea that brews that really doesn't look at non-dominant narratives, which also from within the profession, we see that only some people are given those rights. And this is not something that I'm pinpointing any specific organization or any specific clinician, but systemically, occupational therapists around the world have really been impacted by this problem of not empowering those with disabilities to have their voices heard. Even as clinicians, it's something we do. We speak over people. The last thing I want to mention from a theoretical framework's position is the transnational model, something that I looked into very deeply within my own studies and my postgraduate studies, and that is looking at people who are moving within places and moving within spaces. And specifically, I am focused on forced displacement. Many of the clients you will meet are those people who have been internally or externally displaced forcefully. That they've been moved from place to place, they've been moved from area to area. And as a result of that, we are not looking, when we don't look at where people came from, the cultures, the systems, the societies that they came from, and where they ended up, and we ignore all of that within our assessment, and consequently within our policy, within our process, within our intervention, then we are doing a disservice, an injustice to the client. One of the things I want to mention is from a scholar named Sona Kazemi, who has defined the transnational model of disability as locating the problem in the violence of global class relations, which include systems of oppression like capitalism, imperialism, neocolonialism, the dialects of global politics, the historical infliction of pain upon poor and racialized bodies, which includes colonialism, slavery, indigenous genocide, indentured labor, and the war on terror, exploitative social relations, which are gendered, which are raced, and which are classed, and the destruction of the planet by the ruling bourgeoisie class, causing health issues for every species. So this is a lot. It's a lot of information. It's a lot to take in as a clinician to say, wait a minute, I got to think about all of these things. But to put it in perspective, I want to draw your attention to the picture on the screen. This picture received the 2021 one of the global photography awards by a photographer named a Turkish photographer who basically, when he took this picture, he summed up what's known as the transnational model of disability. Here you have a man who has been impacted by disability with an amputation of one of his lower extremities. He was walking in the streets and a bomb went off and he lost a limb. Today, we see unprecedented times from a clinical perspective, looking at over 1,000 pediatric amputees within the span of a few months. But he holds a child, and this child has a diagnosis of tetraamelia. And this is a condition he was born with, where he has lost, he was born without his upper and lower extremities. And the condition was a direct result of the mother taking medication that she took in response to chemical poisoning. This is the transnational model of disability. If this man was your client and we only addressed the amputation and we said, look, as occupational therapists or as physical therapists, you need some rehabilitation, you need a prosthetic, you need to engage in exercise, we'll look at range of motion, endurance, strength, mobility, without addressing this man's story, without addressing this child's story, we have done a disservice to this family, which I would argue is not client or family-centered care. I'll give a much simpler example. When we meet a client who is not engaging in activities in a school setting, and we don't know if that child is starving, then we may not be able to support that child in terms of handwriting, engaging in occupations related to school. If that child is starving and that child has not had anything to eat or drink, our assessments of ADHD and learning disabilities and handwriting are irrelevant. This is not something that is embedded within occupational therapy models, but more and more day by day, this is something where as occupational therapists or therapists, we can become vocal and educate others on the importance of a transnational model of disability. We talked at the very beginning of this conversation about critical intersectionality. Critical intersections are where we cannot separate our identities, our experiences, or our oppressions. Kimberly Crenshaw is a civil rights activist, a Black activist in the United States, who speaks a lot about the intersection of gender and race. And she says intersectionality is not just about identities. We are not counting and competing. That I identify as certain things and you identify as others. It is about how structures make certain identities the consequence of the vehicle for vulnerability. It is about context, what is happening and what is going on. So when we are in spaces where we're told that the hospital is not a place for politics and that, you know, occupational therapy and conversations around, you know, clinical therapies and clinicians do not take into account social, political, and economic context, that's a very dangerous assumption. And it's a very dangerous premise because while we might not bring politics into this conversation, we are politicized. We are politicized, like I mentioned, by the color of our skin, by our names, by our accents, by the way that we dress, by our nationality. And so either we say, well, we're not going to talk about it, but then we fall into the trap of regurgitating assessments and interventions and supports for clients that are not designed for the clients that we are working with. A quick mention of a term that I have coined in my own work and utilized quite a bit is this concept of xenophobic ableism. This concept of xenophobia is the fear of the other person. When children are being forcibly displaced and their families into other spaces, and there's a lot of hatred towards them, there's a xenophobia. And xenophobia has a direct correlation with ableism. By separating the experiences and impacts of disablement and displacement, the stories of disabled refugees become rewritten through that dominant lens. Xenophobic ableism, it highlights the critical impacts of one form of oppression onto another that further isolates disabled, displaced children or refugee children. Xenophobic ableism, it examines the transnational context of disabled refugees and how xenophobia explicitly leads to the exclusion and discrimination of disabled refugees. And finally, identifying the impacts allow us to shape our own advocacy and our efforts to recognize and challenge it within our societies. So moving forward, within the occupational therapy space and the clinical space, we hear a lot about being culturally aware and sensitive and competent and having that humility to engage with people from different backgrounds, different races, who identify as something that we might not identify with. And there's a lot of this discussion within the field of occupational therapy. However, what I would like to share, what I would like to pose to all of you is that where is this coming from and how do we make it relevant in our clinical settings? This idea that we need to be aware of people's surroundings, it's not about learning about the language they speak or the food that they eat. It's about giving them that quality of human rights that should be an innate quality and that should be given to everyone, but that is not. I believe therapists have this ability to advocate for within healthcare systems, and specifically, and of course I'm biased because I'm an OT, but I believe we have a very integral role in this day and this age. Cultural safety is when all people feel respected. Going to a clinical setting, being able to share what's happened to you, being able to be heard about what's happened to you. Now, many of you might be thinking, well, this is obvious. Obviously, we should be listening to our patients. But the reality that I shared in the first slide, that these patients are the last to be listened to when it comes to displaced settings. Cultural safe practices are free of racism, xenophobia, Islamophobia, discrimination. Cultural safe practices means that I can look and I can dress and I can be who I am. And I can tell you as a healthcare worker, as a patient of a healthcare worker, I can come to you and say, this is my story. And then, only then will we have a conversation about occupation. There's a famous saying, a famous idea within Indigenous health that people are supported to draw strengths from their identity, their culture, and their community. And so this idea that as clinicians, we know it all, or as physicians, there's a hierarchy. They might say, well, we know more than clinicians. And then surgeons might say, well, we know more than physicians, and et cetera, et cetera. That hierarchy, really, the client is at the top of that. And they can draw their strengths from their family, from their community, from their identity. I believe that by addressing the unique challenges faced by displaced children and empowering them to develop essential skills and coping strategies by listening actively to their narratives and not allowing the dominant narrative to speak for those children, about those children, that occupational therapists play a vital role in promoting their resilience and their well-being. So I'm going to stop there. I see there are a few questions. I just wanted to share my personal information. I would appreciate and be honored if any of you wanted to get in touch with me. The organization that I represent is called Smile Canada. That's the website. And if you're on social media, it's at SmileCan. And my personal email address is my first name dot my last name at smilecan.org. And my handle is Sukaina.Dada. So I'm going to stop there and I'm going to just stop the screen and open it up for some questions. I see that there are some questions in the chat.
Thank you so much. It
Sorry,
was a
go
wonderful
ahead.
lecture, and it's such an enlightenment. It opened a new perspective to look at things and to have many questions for our practice in real life. Thank you so much.
Thank you. Thank you. I appreciate it. If anybody has any questions, I'm more than happy to engage. Or if you have any comments or any feedback for me, I'm happy to listen to that as well.
Let's look at the chat. I can see many thank you in the chat. They really enjoyed the lecture. Yeah. So I'll stop by here.